Lastly, the anion gap helps us evaluate acid-base disorders, and it represents the difference between the routinely measured cations, sodium and potassium, and the measured anions, chloride and bicarbonate. The gap reflects unmeasured anions such as proteins, phosphates, lactate, and ketones. When the gap is elevated, it usually signals metabolic acidosis from the accumulation of acids in the blood. The formula for anion gap is sodium plus potassium minus chloride plus bicarbonate. Some labs omit potassium, and a normal anion gap reflects a balance of unmeasured anions and cations, while an increased gap indicates extra acids are present. This is one of the most important calculations in acid-base analysis and is used daily in hospital medicine. The total number of cations must equal the number of anions for the body to remain electrically neutral, and the anion gap highlights those unmeasured anions. When it increases, it signals the presence of additional acids that aren't normally in high amounts. Could be lactate and lactic acidosis or ketones and diabetic ketoacidosis, which helps narrow down the cause of metabolic acidosis. In practice, the anion gap directs further diagnostic workup. If a patient presents with metabolic acidosis and an elevated gap, we immediately think of lactic acidosis, ketoacidosis, renal failure, or toxic ingestions like methanol or ethylene glycol. If this gap is normal, we look for bicarbonate loss or GI losses such as diarrhea, and in this way, the anion gap serves as a diagnostic tool. Now, a common cause of increased anion gap includes lactic acidosis from hypoxia or sepsis, diabetic ketoacidosis, starvation ketosis, and renal failure. Toxins such as salicylates, methanol, and ethylene glycol also produce high gaps. And recognizing a high gap immediately tells us that unmeasured acids are accumulating and urgent intervention might be required. A decreased gap is less common, but it can occur in certain conditions like excessive alkali intake, such as milk alkali syndrome, as well as multiple myeloma, hypercalcemia, hyperaldosteronism, and hyponatremia. A low gap can be overlooked often, but can be clinically significant as well. As always, you interpret via clinical context. And this lecture is to be continued. You'll see that this is part one of two on the comprehensive metabolic panel because we spent this whole time just looking at electrolytes and their importance. When we get back, we are going to look into the kidney and liver and protein and sugar labs that can be done. We'll talk a little bit about diabetes, screening, and interpretation. And then we will look at a couple other nutrients this week as well.